Hi, I'm Neha Pagidipati, and I'm a preventive cardiologist at Duke University, and I'm privileged to also be an associate editor at JACC. And today, I'm very excited to be joined by Dr. Mikhail Kosiborod, who is the Vice President of Research at St. Luke's Health System and also the Director of the Cardiometabolic Center Alliance. Mikhail, welcome, and thank you for joining us.
Thank you, Neha. Always a pleasure.
Well, today we'd like to dive into the suite of STEP-HFpEF secondary analyses that we have just recently published at JACC. We're very excited to see these data because it really does begin to kind of dig into the really amazing results that we're seeing in the original STEP-HFpEF program. So could you kind of begin to walk us through what you took away from these secondary analyses and how we can begin to put this together to understand what we saw in the overall program?
Right. Well, thanks, Neha. And we are certainly very excited to see our work being published in JACC. Well, I mean, from my standpoint, the key message of the program, as far as the main results are concerned, which have now, the original results being published about a year ago now, was really to demonstrate that, we know that, majority of people with heart failure and mildly reduced and preserved ejection fraction are also living with overweight and obesity. And I think the key point of these trials was to demonstrate that obesity is likely not just a comorbidity. It doesn't just accidentally happen to coexist in these patients. It may well be what's causing heart failure in many of these patients. So targeting obesity can produce really substantial improvements in heart failure-related symptoms and physical limitations, exercise function, and a range of other benefits that we saw in the program that we've now demonstrated. But the key question that remained was, what is the mechanisms of benefit? And perhaps, really importantly, one of the most important questions that, most common questions that were being asked after we presented the main results of the two trials was, is semaglutide, the interventions that we tested in the program versus placebo, is it a weight loss drug or is it heart failure drug? In other words, is the benefits that we're seeing just simply due to mechanical unloading from weight loss, or is the drug actually doing something disease modifying to the pathobiology of heart failure, right? And so that's where I think some of the earlier works that we published in JACC is really important when it comes to effects on N-terminal proBNP, for example, being one of the most critical, I think, secondary analysis. And this suite of additional analysis that we are publishing in JACC now is further helping to disentangle the mechanisms and better understand what's actually happening when we treat patients that have obesity-related HFpEF with semaglutide versus placebo. So I think that's really the benefits of this analysis, and I think we're learning quite a bit more from these papers that are coming out in JACC. Just to remind everybody, we have three manuscripts. One has to do with looking at the effects of semaglutide versus placebo in people with versus without atrial fibrillation at baseline and different types of atrial fibrillation. The second one looking at the effects of inflammation as measured by high sensitivity CRP. And then the third is the echocardiographic sub-study of the STEP-HFpEF program. Both trials combined, all of these papers, looking at the combined population of STEP-HFpEF and STEP-HFpEF diabetes.
Well, that's wonderful. One of the things that struck me about the atrial fibrillation paper, maybe we can start with that one. So, if I can just summarize, one of the things that you found was that in patients with atrial fibrillation at baseline, they seem to have an even greater effect of semaglutide on the KCCQ score than individuals without atrial fibrillation. And we didn't necessarily see that impact on some of the other outcomes like 6-minute walk. But we did see it with the KCCQ and, of course, then with the hierarchical component, which the hierarchical composite, which is probably driven by the KCCQ. So one question that I'm sure many people have is, why? Why did there appear to be greater benefit in people with atrial fibrillation for KCCQ? And also, why not some of the other outcomes? Do you have any hypotheses about that?
Yeah, so the effects that you just mentioned, Neha, is quite striking. I mean, we're talking about nearly 3 times the effect on improving symptoms and physical limitations in people with atrial fibrillation versus in those without. And just to be clear, people who didn't have atrial fibrillation at baseline still had a large benefit with semaglutide.
Right.
So that's, I think, is important to remind folks about. But as I said, it's almost 3 times as large in people who had AFib, and it also didn't matter what kind of AFib they had, paroxysmal, persistent, or permanent. Now, it's a great question of why would that be the case? And, I guess the natural place that people normally go to is to say, well, maybe they lost more weight for whatever reason. Maybe that subgroup, tended to lose more weight. Maybe they just had greater weight loss benefit, but that certainly is not the case. In fact, there was absolutely no difference in the degree of weight loss that these patients experienced versus those who didn't have atrial fibrillation. So that's another example of this decoupling between the magnitude of improvement in heart failure outcomes and the magnitude of weight loss. And we've observed that before with other measures of heart failure severity. And just to be clear, also, what we're seeing in this paper, perhaps not surprising, and by the way, almost half of the patients in the trial had atrial fibrillation, is that clearly people with atrial fibrillation have more features of more advanced heart failure. They had much higher N-terminal proBNP, much higher proportion of these people were on loop diuretics, for example, and there were some other features, higher NYHA, high proportion of people with NYHA 3 and 4 versus 2 in those with versus without atrial fibrillation. So clearly they have some features of more advanced heart failure. And what we saw previously is other patients that had different features of more advanced heart failure. For example, I'll just give you one example, those that were on loop diuretics versus not, or those that had much higher NT-proBNP at baseline than those that had lower NT-proBNP also get more symptomatic benefit with semaglutide, even though they don't lose any more weight than other patients that have less severe heart failure. So, so I think what we're seeing here in this analysis is very much consistent with the message we've been observing all along, which is regardless how we slice or dice it, people with more severe heart failure benefit more. Now, why would that be the case? And I think it goes back to this, critical question: is it the weight loss or is it the disease-modifying effect on heart failure pathobiology? And I guess my theory, right? I mean, it's very difficult to precisely point to the mechanism in trials like STEP-HFpEF and STEP-HFpEF diabetes, which are designed to answer certain questions, but they're not necessarily purely mechanistic studies. But we can start getting to the answers. And the way I put it together is if you have more advanced heart failure, a decongestive effect, which we clearly see with semaglutide, right? In the NT-proBNP analysis, we demonstrated that not only does semaglutide reduce NT-proBNP, but semaglutide reduces NT-proBNP entirely independent of weight loss. Even people who lose between 0 and 5% of body weight have large reductions in NT-proBNP with semaglutide versus placebo. So it's clearly not a weight loss. It doesn't appear to be a weight loss effect, certainly not purely weight loss. So if you decongest a patient who is more congested to begin with, even if it's the same degree of decongestion in relative terms, in absolute terms, you would expect that that would have a larger benefit, right? I mean, I'm just, kind of now switching to a clinical example, right? If you have somebody who's coming in really severe decompensated heart failure, decongesting that patient with diuretic therapy, even with the same amount of diuresis, will probably dramatically improve the patient's symptoms versus somebody just has mild symptoms, right? So I think that's probably what we're observing is that, if the decongestion is the critical component of what's going on here, it'll have presumably a larger effect on somebody who's more decompensated or more congested, or it has more severe heart failure than somebody who's got less severe heart failure. At least, that's the ways that I put it together. And I think the other papers that we also are publishing at the same time, kind of, at least some data from those other analyses kind of seem to support that storyline as well.
Yeah, I completely agree. And that was kind of what I took away as well. From the inflammation paper, I have to say I was kind of surprised by the results. And there were a couple of things that really surprised me. One was that the reduction in CRP that we see with semaglutide did not seem to be related to weight loss. I had thought maybe CRP reduction comes along with weight loss, but it seems to be reducing CRP, not necessarily in a way that's related or entirely related to weight loss. And then the second component, that surprised me was that the benefit of semaglutide was there and the same, regardless of whether or not people had elevated CRP at baseline. And if we think that inflammation reduction is a primary driver of the benefit of semaglutide, you might have expected to see greater benefit in those with elevated CRP at baseline.
Right. Well, I think when you see this degree of reduction in inflammation, we're talking about roughly about a 40% decline in CRP, right? So it's a very large effect. And I got to say, we knew from other trials, certainly not in people with heart failure, but in other populations of patients that have been treated with medications like semaglutide and other GLP-1 receptor agonists, that there does appear to be an anti-inflammatory effect that is direct and not necessarily linked purely to weight loss. CRP does go down when you lose weight, but it appears to go down with GLP-1 receptor agonist. Certainly, semaglutide has been, we've known for some time that there's probably some direct effect on anti-inflammatory effect as well. And so you're right. It's, what we see here is that CRP goes down, and there isn't certainly a one-to-one relationship between CRP declining and weight loss magnitude. And that doesn't mean that it's entirely weight loss independent. But it suggests that it's not all about weight loss, which I think is important to see that in this particular patient population. And then, of course, the other question is, regardless of how much of CRP reduction is weight loss related or unrelated, how much is CRP of a mechanism in terms of benefits that we see from a heart failure standpoint? And again, we've got to be careful a bit, right? Because ultimately, we're dissecting mechanisms that the trials were not necessarily predominantly designed to address. And so, but with that limitation acknowledged, and the other limitation being just that, and every time you look at subgroup analysis, there are power limitations too.
Right.
But with that, with those limitations acknowledged, I think it certainly doesn't appear to be a cut and dry answer here that inflammation is a key mechanism. It may be one of the mechanisms still, but we see that regardless of CRP levels at baseline, for example, the heart failure symptoms, physical limitations, exercise function, NT-proBNP levels, hierarchical composites, it includes clinical events, all of those outcomes get better regardless of what the CRP level is. So, by the way, about 70% of patients in the trial had elevated CRP, and a number had really high CRP, which is actually interesting, like above 10, which is very high levels of inflammation. So this is clearly a population of patients that has high degree of inflammation. But this is a really important question, right? Because we're now developing therapeutics that specifically address inflammation and HFpEF, and I think it'll be, ultimately that will be the answer, right? So there are medications being tested now in this patient population that have no effect on weight loss,
right?
But are purely designed to lower inflammation. And I think it'll be really, really interesting to see what happens. Is addressing inflammation directly independent of much broader cardiometabolic effects like the ones that semaglutide has, but with much more honed in anti-inflammatory therapeutic agents, is it actually going to make a difference? And I think we'll have to wait and see. But just maybe the last facet I will mention about that analysis is, interestingly enough, as the one positive relationship we did observe was between greater reduction of CRP levels and greater reduction in NT-proBNP levels. And again, coming back to the point I made earlier, which is if it's decongestion, maybe a reduction in inflammation is, at least to some extent, related to that, and maybe it is one of the mechanisms. I think the best way I can summarize the lessons from this analysis is that inflammation may be important, but it certainly doesn't appear to be the kind of fundamental, critical component of what's going on. I think it's part and parcel of what's going on, but it probably is not the explanation for everything we see here.
Right. Well, I think that these analyses really help us to understand more what's going on, given the limitations, like you said, with secondary analyses and power and so forth. But of course, one of the big remaining questions is what will the impact of semaglutide be on kind of harder heart failure outcomes? And I know that that's something that you're looking into as well.
Yes, we are. And I think just to mention, one remaining piece here, we were always asked when we presented the data, well, do you have data on, I'm talking about the main results, do you have data on what happens in the heart? Do you have any remodeling data? And actually, the third analysis that we are publishing in JACC now actually has to do exactly with that. So we had a very large echocardiographic sub-study where we had several hundred patients across the program have baseline and follow-up echocardiograms that were reviewed and analyzed in our core lab. And I think that analysis is quite interesting as well. The bottom line is that do appear to be important remodeling effects of semaglutide. The probably most important to mention is that there is effect on left atrial volume. So left atrial volume goes up quite a bit in people treated with placebo over time, but it goes up to a much lesser extent in people treated with semaglutide. And there are also effect on right ventricular remodeling as well. And if you were to postulate that decongestion is the key mechanism here, which is what we've pretty much been talking about, right? Is everything seems to point in that direction, and certainly not directly or entirely linked to weight loss. Then if it's decongestion, that's exactly where you would expect to see the benefit is, left atrial volume, right ventricular remodeling, which is exactly what we're observing. We don't see much of a change in left ventricular structure and function. There are some positive effects on diastolic function in the left ventricle, which again, you would expect if there is a significant decongestion effect. So I think the story is it's very nice because the messages all kind of come together to point in that direction mechanistically. And I think that becomes a very compelling story with essentially suggesting semaglutide is truly disease-modifying therapy in these patients, not just mechanical unloading for weight loss. That's, I think, is the key message here across all of this analysis. Now, as you said, the critical remaining question is what happens with hard outcomes, right? We did have a signal in the programs that we published in the original papers and the original pooled analysis of the two trials, which showed fewer events of heart failure hospitalizations and urgent visits. But the number of those events with semaglutide versus placebo, but the number of those events was quite small. And so it certainly wasn't definitive in any way. And what we actually did is pool the patient or participant level data from the two STEP-HFpEF trials, as well as SELECT and FLOW. So SELECT, just to remind folks, was a very large, more than 17,000 patient trial of people with ASCVD and obesity, but no type 2 diabetes. It was a cardiovascular outcome trial with a 3-point MACE, traditional 3-point MACE primary endpoint. But and FLOW was, of course, a trial of semaglutide in people with diabetes and chronic kidney disease. But the critical feature of these two trials is that there was information collected from investigators on history of heart failure, and more specifically, what kind of heart failure they had. And there was also echocardiographic data on ejection fraction and NYHA functional class available in the large proportion of those patients who had heart failure at baseline. And so what we did essentially is pool the participant level data from those that had history of HFpEF from SELECT and FLOW and combined it with the data, participant level data from STEP, HFpEF and STEP-HFpEF diabetes. And we ended up with a pretty large patient population of about just under 4,000 patients. And we looked at the effects of semaglutide versus placebo in that pooled population on hard outcomes of cardiovascular death and hospitalizations, urgent visits for heart failure. And I think the analysis are quite striking. There is a large reduction in those events with semaglutide versus placebo, at 31% relative risk reduction in the composite of cardiovascular death and worsening heart failure events, and a 41% reduction in heart failure events alone. There was the hazard ratio for cardiovascular death was 0.82. It did not reach statistical significance, in large part, I think, because there were relatively few events of cardiovascular death, even when we pulled the data across the trials. There was just over 100 events of cardiovascular death, and certainly would need more events to show a definitive benefit on that particular outcome. So I think this certainly positions incretin-based treatments very well for future large cardiovascular outcome trials because the data is looking very compelling. But I think we now have additional data strongly pointing towards not only benefits on symptoms and function and surrogates of congestion like NT-proBNP, inflammation, and so forth, but also heart clinical events as well, which I think is of critical importance clinically.
Well, Mikhail, this has been phenomenal because you've really helped us to kind of put all of these papers in context and really understand what we're seeing in these various papers. And so, congratulations on this amazing work, and thank you so much for taking the time to talk to us today.
Oh, it's my pleasure, and many thanks for the partnership with JACC. We really appreciate the opportunity to see our work published.